All right. I think let's just go ahead and get started. We'll do intros, and then if anyone else is a little bit later, they'll catch on once Michelle starts. So first of all, we just want to say welcome. Thank you so much for being here. Whether this is the first one you've attended or the sixth one you've attended, we just appreciate you taking the time out of your day to come hear from us and our staff, and maybe learn a little bit and see if there's anything we might be able to do to help you. Second of all, happy Labor Day. I hope that everyone had a safe Labor Day and had some fun, got some sun, and maybe did some resting, fingers crossed. And if you do have people going back to school today or this week, congratulations to you. Maybe get a little bit of time back in your schedule. But again, yeah, we just appreciate you being here and hope that this is informative for you. If you're here, you probably either have headaches yourself or migraines, or you know someone who does and thought this might be helpful. As a reminder, this is recorded just like all of our other Tuesday talks we've had. And we will send the link out afterwards if you want to rewatch it or send it to anyone that you know that might be interested in learning a little bit more. Before we get going, I just want to do a little housekeeping. If you have any questions, please just don't include any of your own personal health information in the chat. But if you have a question on the very bottom, there should be a Q&A tab. You can just put your question right in there. We'll answer them at the end. And other than that, I think we will get right into it. I'm going to have Michelle just jump to the next slide, do a quick intro of our providers. We have Dr. Belling, Dr. Kinder, and Michelle here on the video. So I'm just going to start with Dr. Belling. If you want to just say a quick hello, and then go to Dr. Kinder, and then Michelle, you can take it away from there. So Dr. Belling, take it away.
Yeah, thank you all for joining us. This is I believe our sixth Tuesday talk, and Michelle is going to be giving a good talk, just kind of a general overview of headaches and different types of headaches and their treatment. So if you haven't taken part in one of these talks, I think you'll enjoy it, and I will then pass it on to Dr. Kinder.
Hello, everybody. Thank you for all of you that are here today on the video, and anybody of you in the future who are going to watch this later on. I hope that you're going to get something good out of this conversation. It's a challenging topic, but it's a fun one to talk about. I'm Dr. Kinder. I've been here since the beginning of the year. It feels like not too long ago, but this last 8+ months has really flown by. I've been really excited to be a part of this team. It's a great group of providers, and we're trying to do the right thing and try to spread really good information out there to help all of you be able to manage your pain a little bit better. So it's nice to meet you.
Hi, everyone. I'm Michelle. I'm going to be giving your talk today on headaches. It's a heavy topic. It's a pretty broad topic. So let's dive into it. So today we're kind of going to go over types of headaches. And whenever I go over the types of headaches, I don't want you to think like these are the only types of headaches that you can. Whenever we kind of think about headaches, it is very broad and is a huge umbrella. I'm going to kind of narrow it down to things that we see here in the clinic and things that are most common. We're going to talk about treatment options for headaches, and then we'll open it up for questions at the end. So whenever we discuss headaches, I think what's important to realize is we discuss headaches as being a primary headache or a secondary headache. So if we're talking about a primary headache, meaning a tension, a migraine, a cluster headache, those headaches, they are the primary source of your pain. Like that is the reason that you are having a headache. These are approximately 90% of headaches that individuals get. And unfortunately, they're typically idiopathic, meaning we kind of don't know why you're getting them. You're just getting them. If you notice in that column, I also have occipital neuralgia. It's one of those that can kind of float between a primary and a secondary headache. Whenever we discuss secondary headaches, that means something else is pathologically going on in the body that's causing your headache. So I'm sure you've noticed, like I have meningitis, I have hemorrhages, intracranial hypertension, hypertensive crises, glaucoma, and another one is cervicogenic headaches. That means something is happening, whether it's something inside the head or outside the body, maybe your blood pressure is up, or maybe it's coming from your spine, that is causing your headaches. All right, so for today's discussion, I kind of wanted to focus it in on tension, migraine cluster, occipital neuralgia, because we see quite a bit of that here in the clinic, and cervicogenic headaches, which we also see quite a bit of too. So I'm sure if you had any kind of like stressful weekend or anything that kind of changes in your environment, I'm pretty sure you are familiar with a tension headache. It is the most common type of headache overall. Symptoms can be like a constant daily headache. It's typically felt on both sides of the head. It can almost feel like a tight band around your head, or I've even had some people say it feels like my head is in a vice, like nothing is helping it. Worsens with stress, fatigue, noise or glare. But the thing about a tension headache is you usually don't have the pulsation, like you can't feel your pulse like going through your head. And the other thing is it usually doesn't come with nausea, vomiting, or any neurological symptoms, meaning auras or changes in sight or how you're hearing things or auditory things. Treatment for your tension headaches include first line always NSAIDs, aspirin, acetaminophen. If you're working with those and those don't work, sometimes you can move on to migraine medications. There's some antidepressants that can actually work, and those are typically reserved for people who have severe recurrent cases or for prophylaxis. Beta blockers and psychotherapy can also work well for tension headaches. And I think we see quite a bit of migraines coming through the clinic as well. Migraines are typically categorized as migraines without aura or a migraine with aura. So what are auras? Those are typically those visual changes that you get, the flashing of lights, zigzag lines, blind spots, anything that kind of happens through there. You can have aphasia, which is an impairment of your language. You can have weakness and numbness even associated with that as well. They usually last, these auras typically last less than 60 minutes, and they're usually at the onset of your headache. Signs and symptoms, they're typically one-sided. They're pulsatile. They'll have a throbbing sensation in your head, and they typically are associated with nausea and vomiting. You're likely going to have sensitivity to light and sound, and it worsens with physical activity, stress, or lack or excessive amount of sleep, alcohol, and specific foods. Management for migraines, typically, these are things that we would see like if a patient come into the ER. We want to do something that's kind of abortive in nature. We'll give triptans, which would be your rizatriptan or your sumatriptan, or ergotamines, which is like your Caragot and your ergomat. Dopamine blockers can also be used. IV fluids, keep the patient in a dark, quiet room, and give them medication to keep them from feeling nauseous. Also things that help are NSAIDs and acetaminophen, as well as caffeine. Prophylactically, how we help manage migraines is going to be, you can try beta blockers or calcium channel blockers, so blood pressure medications. Once again, the tricyclic antidepressants. In some cases, anticonvulsants have been able to help control your migraine pattern. One of the new things that have kind of come onto the market, and I'm sure you've seen plenty of commercials for it on TV, is your calcitonin gene-related peptide antagonist, which is kind of a mouthful. But these are your medications. Typically, they're injectables. It's Emgality, Aimovig, and Ajovy. These have been really successful in helping people who have migraines who are not responding to any of the other medications. Some of the other techniques and therapies that we use is Botox, as well as biofeedback therapy. One of the other type of headaches that we have is called a cluster headache. These aren't so frequent necessarily here within our facility, but I have seen them in the ER setting quite often. They say that it's predominantly in young and middle-aged males, but I will tell you, I've seen my fair share of females with cluster headaches as well. These are severe one-sided headaches. They tend to land either around the eye or just feel like it's behind the eye, as well as in the temporal area. They last for less than 2 hours and they just kind of just resolve. But they occur several times throughout the day over 6 to 8 weeks, which gives it the name cluster. It's worse at night, or if you drink alcohol, if you have stress or food. It's usually you have something called Horner's syndrome, and it's one-sided nasal congestion or drainage, redness of the eye, and tearing of the eye. I think the thing that fascinates me the most about this type of headache is its first-line treatment is just 100% oxygen. I've actually seen this used on people, and it works very, very well. Give them a nasal cannula with 100% oxygen, and their symptoms resolve. You can also use anti-migraine medications, like we talked about before, and you can, for prophylaxis, like if this is something that continues to happen, you can try verapamil. Occipital neuralgia. This is something that we definitely see quite a bit here in the clinic. It's typically one-sided, but I will tell you, we have a lot of patients that it does happen on both sides. This is pain that originates in the top of the neck and radiates upward. And I can tell you from experience that if a patient is having this type of headache, they can pinpoint right to where it's happening and exactly where it's coming up, which is typically one of the injection sites that we have. You can also have scalp tenderness and sensitivity, and you can be sensitive to light as well. Treatments include massage and rest, antidepressants, and greater and lesser occipital nerve blocks, which typically, if you're coming to us for these type of headaches, that's generally where we start. In the past, I've noticed most people have tried pretty much everything. This is something that they can't get rid of. So we're more than happy to be able to do these blocks here in the clinic and help you out with that pain. All right, so the next one, cervicogenic headaches. So these type of headaches, typically one-sided, they're not so much they're non-throbbing, can radiate up into the frontal scalp and down into one shoulder or arm. That typically comes from, there's a nerve being pinched, or sometimes arthritis is building up in that C2-3 and C3-4 area. What's happening is it's creating a pinching on those nerves, and it's causing the pain. And it's typically what we call referred pain. It's radiating pain from the cervical spine. Worsens with flexion and rotational movements of the neck. So one of the treatment options that we have for that is we start with the C2-3 and C3-4 diagnostic facet joint blocks. If you do really well with the blocks, then we can move you on to the RF neurotomy of those levels. Other things we like to do for this is stretching, postural exercises. We want to make sure that you're working, that you're having good body position whenever you're working at home and in the workplace. Heat and ice, as well as NSAIDs, analgesics and muscle relaxers have been shown to help, and even trigger point injections. So that kind of leads us to the end of our slideshow. If you have any questions, I would be more than happy to answer them for you.
I'm going to start with one question. Maybe that'll get people's brains rolling a little bit. Can you or do you ever see patients with multiple types that you just listed, i.e. with occipital neuralgia and a different, just migraine headaches, or is it usually one or the other? Can you kind of explain that a little bit?
Yeah, I think pain is definitely, I think we all use the onion metaphor here quite a bit. Yes, there's people who can have migraines and they are pretty cut and dry. No, that's a migraine. And there's also people who have like cervicogenic headaches. Like I have issues in the upper part of my cervical spine and it's also causing a headache. I think that's what's important about doing a physical exam, like a proper physical exam, and kind of teasing out, is this kind of your migraine presentation, or is this something else that's happening? So very possible.
Can you explain a little bit more about the drugs that I don't remember all of the name of them, but you called it a mouthful, and kind of what those medicines do and who they might be particularly good for, like Emgality and those types of things, because I know that we do offer those here and what that might look like.
Yeah, absolutely. So let me go back to that slide because it really is a mouthful. So what they're finding, and these are pretty new to the scene. And whenever we were kind of discussing like migraine management, I was like, there's so many meds out there, correct? If you're watching any kind of TV, you're going to see an advertisement for either a diabetic medication or you're going to see something for a migraine medication, guarantee, anytime. So the GCRP antagonist, what they're finding is they're thinking that this particular peptide, whenever it bonds to receptors in the brain, it is what's triggering migraine headaches. So what they have found is something to block. This would be, so if you're thinking like in the brain, you have receptors. What happens is these particular peptides apply to those receptors, and through modern medicine and just awesomeness, they found ways to block it. And that's what that drug does. It blocks that from adhering to that particular receptor. And you keep from having the headache, essentially. With these medications, I tend to lean a little bit towards the Emgality. And I also kind of lean to that whenever other things have failed. I do know insurance companies kind of have, they want to make sure that you've tried everything before you go to a antagonist. But what I have seen from it is people have went from having daily migraines down to their migraine pattern being reduced to almost 2 or 3 a month. And I think if you're having these daily episodes of migraines and just horrible pain, like your quality of life is just drastically decreased, and then you introduce a medication and you take that migraine pattern to like maybe 1 or 2 a month, like the amount of life that you can live just having that having that reduction in pain is amazing. Like I said, this is typically somebody I would try to reserve this a little bit towards the end. But I will tell you, 9 times out of 10, if a patient is coming to us for migraine therapy, their primary care provider, maybe even their neurologist, they have went through the beta blockers, calcium channel blockers, the antidepressants, the anticonvulsants. The only other thing that maybe they haven't tried is Botox at that time. So
okay,
that's kind of
okay. We have someone who's kind of explaining a little bit of what they experience. So I'm gonna ask a question, given some of these details. So this guest is saying that they thought that they had migraines, but that they're lasting for a really long time, between 12 and 14 hours. So really lasting a long time, maybe longer than a typical migraine might be. And they are coming with vomiting and nausea. So can you kind of walk through, not looking for any sort of diagnosis, but your process of, okay, if you're hearing some of those symptoms, what might be your first thoughts due to the length of time of the symptoms and the aura that you're having. I see Dr. Kinder, you jumped on as well, so feel free to either of you to answer if you have a better thought.
Yeah, I think having a migraine last for 12 plus hours associated with nausea and vomiting, there's just a plethora of other questions that I want to ask.
Yeah.
It's not something that I just like, oh, yep, that's a migraine.
Sure.
I will tell you personally, like if somebody comes to me with a headache, there's a million things kind of going on in my mind. Is this something that's acute? Is this something that they really need to go, see somebody else for this? Like this is a neurology path. That's kind of what I alluded to, like in the beginning, like migraines, headaches. It's a huge umbrella. There's a lot of situations where whenever people are explaining their symptoms to me that throw up red flags, like, is this acute? Did it come on quickly? I guess without just getting into somebody's medical history here, everybody's migraine pattern can fluctuate a little bit, but if you're having these symptoms, they're not going away. If you're trying over-the-counter stuff and it's not working, then it's something that I would recommend that you be seen, either come see us or go see your primary care to make sure that there isn't something else happening under there. Dr. Kinder, do you have any other advice?
I think that's a really good explanation. When something's a little atypical, we want to make sure that we're investigating that thoroughly, making sure that we're ruling out things that could be scary, potentially life-threatening. That being said, this description of a migraine headache that lasts for 12 to 14 hours associated at the beginning with nausea and vomiting, unfortunately, that can be a normal presentation of migraine headaches for some patients. Maybe that happens once a month, maybe it happens a few times a month. Some people even have a variation of this where the migraine virtually doesn't go away and just goes on for days and days. And we call that status migrainous. It's a known condition. So I like Michelle's discussion about ruling out all the other stuff, looking for anything that's unusual, atypical, so that we can make sure that we're keeping our patients safe and that we're treating the right condition and the right underlying cause of the issue. I did want to use this time just to bring up one other treatment option that I don't think was brought up with this talk yet. And it fits on this slide that we have up right now, but it also fits on the previous slide, which is for treating abortively treating the headache, instantly taking the headache away. And it's a procedure called a sphenopalatine ganglion block. It's also known as an SPG block. And it's one of the only procedures that we do that doesn't actually use a needle typically. And we block this ganglion that sits behind some soft tissue at the back. You go up the nasal passage to get it towards this ganglion. And this is a procedure that's been helpful in emergency rooms for patients that are coming in with status migrainous or a headache that's causing nausea and vomiting that's lasting for hours or days. And this is a procedure that sometimes is able to just reset the circuitry and get that headache under better control right away. But it can also be used as a prophylactic or a preventative treatment to prevent the frequency and severity of the headaches. And it's also used along with cluster headaches, which we talked about earlier, along with migraines. So it's just another therapy that we keep in our back pocket that we're able to do to help folks in different situations.
Great, thank you. That was super helpful. Okay, we have another question about what it looks like for the cause of migraines or headaches with hormones and how hormones could play a role in that, and specifically women in perimenopause and what the likelihood is of getting more headaches or migraines as you get older as a man or woman with your migraine or with your hormones. Anyone can respond. That's a big question, so feel free to jump in as you need to.
All right.
I can address it.
All right.
So unfortunately, migraines associated with menstrual periods or menopause are pretty common in women, just because of the hormonal fluctuations that go on. And, migraines can have, different causes. And in women, one of those causes can be hormonal fluctuations. So the treatment for those really is not going to change much from, what's been done for, how you treat other migraines. You can, have some woman see their gynecologist, try and go on some sort of hormone therapy. And sometimes that can help either lessen them or even get rid of them altogether. But that's just, unfortunately, it's just one of the causes of migraines in women. But you also don't want to just automatically assign, just because someone, if a woman comes in and she's having migraine headaches, you don't want to just say, oh, it's just because you're having hormone fluctuations. So you have to go through and make sure that there isn't some other cause. The most important thing is to, if it's an acute migraine headache, to get it under control and then find some sort of treatment and go through the treatment protocols that Michelle described, of being able to reduce the onset of those headaches and the frequency. So yeah, I wish there was a different answer, but yeah, if for women, that is just one of the causes of migraines. So if anyone else wants to chime in.
I think there's the silence is speaking, that they felt like your answer was sufficient.
Okay.
Okay, well, I am not seeing any more questions come in, so I just want to let's move down a little bit in the slides here. And I just want to thank you guys again for coming. This has been recorded, and I just wanted to remind you all that the last 5 that we've had as well were also recorded, so you can find these on our website or on our YouTube channel. And you can watch them yourselves or send them to anybody that you think might be interested in them. This is a list of all the different Tuesday talks that we had. They're all right around 30 minutes, so not super long. And they all had an open question and answer at the end, with people asking specific questions that they're going through. So all really helpful and really informative. If you have any questions about today's Tuesday talk, or if you are interested in scheduling an appointment or being seen, right now we typically have a consult within about a week. And then if you'll see one of these lovely providers and kind of work through what the best options are for you. So let's go one more slide, Michelle. I just want to pull up our main website and phone number. So that's our phone number. We have an email. You can email us directly for an appointment or just give us a call. But we are so glad you came. We hope you have a wonderful rest of your day. And I just want to open the floor to the providers one more time if there's anything else you guys wanted to add, or just sign off.
I just wanted to thank everybody for being here today. I appreciate it.
Thank you, Michelle. We appreciate you.
Thanks for your time and attendance today, everyone. And hopefully we'll be able to help you if you come in.
Thank you. Have a great day, everyone.